So thank you everyone for joining me today for my practicum as part of my DBA. And I'm going to talk today about perception of acuity, risk, losses and gains, addressing emergency overcrowding in the UK. I'm going to ask that you all leave questions for the end of the presentation, and I'm not going to go around for introductions of everyone who's present today. But I would ask that if you do ask a question at the end, if you can just say your name and a short introduction of your background so that everyone just knows what you're doing. So just about me, I'm Gijsbert Fourie. I'm a GP by background, currently Deputy Medical Director for Cambridge and Peterborough Integrated Care Board. I'm also currently doing a doctoral of business administration at Holt International Business School. And I would like to just introduce one person, Niels Olsen, who's a professor at Holt and my supervisor for the DBA program. This practicum is part of my data visualization and communication course. And it's to demonstrate to you what I've done so far. So just a quick introduction to the background and the objective. So my objective of this project is to accurately identify behaviors, habits, and perceptions that influence patients' decisions to attend the emergency department for what we see as minor medical conditions. And by doing that, I'm using accumulative prospect theory models to try and identify these. So I want to know the why behind the why. As background to the problem, a report for NHS England concluded that the year-on-year demand and growth for emergency department care for minor medical conditions is not sustainable. On the 24th of September 2021, the Guardian newspaper reported that the NHS is in crisis. Emergency departments across the UK are so crowded that 50% hold sick patients outside in ambulances or turn them away completely. As you're also aware, we've heard that this year, there's also been deaths of patients waiting in the back of an ambulance for the care that they need. A literature review that I've done showed that this has actually been a problem from as early as the 1970s. The reasons for these attendances seem to be the same in all the research that's been done so far. And one of them is access to primary care. And that is despite all the efforts we've done over the years to improve access to primary care. So from all this, it concluded that we don't fully know the true reasons for the increase that we are seeing in the demand for emergency care. So I decided to do a data collection and created a survey questionnaire to do this. I've done it a slight bit different than the ones that I found in the literature reviews, in the sense that I sent it out to patients on a randomized sort of basis, with not knowing whether they've attended emergency departments or primary care or not. Most of the studies and surveys that I found in my literature review was done when the patient was in the emergency department, when they were in the acute situation, having made that decision. So I wanted to understand what is happening before that point, before they need to make that decision and attend the emergency care. What is the thoughts and the decision process that they use to come to that? So I developed a survey with custom designed questions. I used mTurk, which is Mechanical Turk, and it's an Amazon web-based service, to distribute the surveys and collect them anonymously. I looked at the population of England because I wanted to only send these to patients or people in the England region, which was approximately 58 million on the 2021 ONS data. I used Qualtrics sample size calculator, and the ideal sample that I needed to do for this project was to get 385 responses. During the time, I managed to get 417 completed surveys. I used SPSS for data cleaning and analysis, and I was able to use 413 samples for data analysis at the end. That's after exclusion of incomplete samples. By incomplete samples, that's where they've consented to the data being collected, but they didn't actually complete any of the questions in the survey. So the findings. Now, a lot of the findings that I'm going to demonstrate, and I'm only going to demonstrate a couple of findings, would not surprise you. It's things that we know. But the question there is, why are these still coming up? So one is that we can see that there's a clear association between the increase in age of patients and the decision to attend the emergency department. And it's particular from the age groups between 66 to 75, and then there's a sharp incline to the over 75s. In contrast, most people choosing to attend primary care, according to the survey, falls in the age group between 36 and 45, with a very sharp decline in the age group between 66 and 75, and a slight increase again towards the over 75s. Just looking at these two together, we can see that there's a clear divergence between the two lines, with an upward trajectory for age and outcome or choosing to attend emergency department for minor medical conditions, and a downward trajectory for choosing to attend primary care setting for minor medical conditions as age progresses. I then also wanted to ask the respondents that if you choose to attend the emergency department for minor medical conditions, what would need to be done to change that? What would we need to do and put in place so that you actually choose primary care to be your first point of contact for minor medical condition? And again, unsurprisingly, 71.4% said 8 to 8 opening 7 days a week. 69% convenience of booking appointments online. And 57.1% asked for more diagnostics to be available in primary care. So why is this still an issue? Why has all the things that we've put in place, the increase in appointments, extended access, not really made a difference in patients' decisions to attend emergency departments for minor medical conditions? So the next finding that I sort of introduced was to understand this process and how they assess the risks or losses that they can make. So one thing that stood out was that there was a clear association between the patient's perceived level of immediacy and their decision to attend the emergency department. So as their perceived level of immediacy increases, the chance of them attending the emergency department for that problem increased as well. And it increased significantly. So do we understand the patient's perceptions of these minor medical conditions and the immediacy about it well enough? Or is there a gap? The other point is that as the perceived immediacy decreases, the decision in attending the primary care setting. So the more they see immediacy increase, they also decide that primary care is not the best place to attend for these. But is this perception about the level of immediacy for these minor medical conditions correct? Or is this something that we can do about this to make patients understand what immediacy is and where these conditions are best placed to be cared for? I also had a free text section in the survey. And again, this will not be surprising to us, as a lot of the patients said that it's difficult to get an initial appointment with primary care. That can be a problem, and that causes a reluctance in the end by the patient to attend or to be seen in primary care. The waits are so long that they are scared that the condition will get more serious if they wait. They prefer face-to-face appointments as they feel it's not effective to be diagnosed or managed over the phone. They contacted their GPs several times, so although they didn't see this as a reason to attend emergency departments, they feel that for a lot of people it will be. Most healthcare professionals are extremely efficient, and they also help them with their problems. So this particular patient decides to visit their GP more regularly. It's just that much harder to get appointments these days. And there was a lot of patients who commented that they just feel it's impossible to get any good GP care in the UK nowadays. So just a quick summary of the findings. So age still play and is an important factor in patients deciding between primary care and emergency department care for minor medical conditions. 71.4% want primary care to be open 8 to 8, 7 days a week. 69% improved ease of booking online appointments, and 57.1% more diagnoses in primary care to make primary care their preferred choice of care for minor medical conditions. Getting an appointment is difficult, especially face-to-face. But what we don't know that much about or fully understand is the perceived level of immediacy that is a major factor in the patient's decision to attend the emergency department. So from these findings, just a few recommendations that I would sort of put forward is we need to really make an effort to better understand the patient's perception of immediacy so that we can use that knowledge in deciding how we need to better provide and reform provision of emergency care in our region. We need to improve the immediate care provision for all the patients in the community, because as we saw again, as the level of immediacy goes up, or the perceived level of immediacy goes up, patients in the older age groups decide to attend the emergency department. We need to investigate why efforts to improve access to primary care is failing, while in the meantime, we make improvements in ease of online appointment bookings. We need to increase the access to more diagnostics in primary care, and we also need to improve patient awareness of primary care services that are available at the moment. Thank you for listening, and I would now like to open the floor to any questions.
Hi, Kees. It's Kevin Webb. I'm a GP in Cambridge. Thanks, Kees. It's a very interesting presentation, and probably confirms a few things we suspected. But it's very interesting about the perceived immediacy. Do you have any examples of what sort of perceived immediacy problems that people presented with? Do they give you any examples of that?
Yeah, so when I did the questionnaire, I've asked the same question about whether they think it's best place to present for care in primary care or emergency care. And the conditions listed were COPD, asthma, diabetes, cancer, ankle injury, suspected acute myocardial infarction, and stroke. And on these, the patient agreed on a rating scale, a 7-point rating scale, on whether they mostly disagreed or mostly agreed, strongly agreed. And then I used that to analyze data, work out the means, and various other data analysis techniques to come to the conclusions. Just on that point, because this was newly developed and custom-made questions, we did what's called the Cronbach Alpha as well. And that's a reliability test. So all the questions that I used in the survey came back as satisfactory to very good. So that kind of validates the data that I got from the questionnaire.
Is that a resample?
Yes.
Yeah. Okay. Thank you.
Did that answer your question, Kevin?
Yes, it was interesting. Yeah, because I think it's probably the things I would thought would go to perceived immediacy. We've sort of trained people that if they have chest pain, they should go to ED. So yes, it's probably part of the problem about training of populations, why they perceive the immediacy the way they do. But thanks for answering the question.
I could see there's 2 more hands up, but I can't see who those are with being on presentation screen. So anyone can just ask the question.
Shall I go first? Hi, I'm Dr. Damon Scambry. I'm a GP in Huntingdon. So my question is, or it's just a thought really. So do we know why the perceived immediacy is so high? Can you speculate, or is this like another level of research that needs to be done?
So my speculation, but there will need to be more research that needs to be done, I think is kind of what Kevin touched on, is it perhaps is what we tell patients or not tell patients. So some of it will be coming down to education. And actually having the time to spend to patients when we make a diagnosis or see them in consultations for that kind of safety net and explain the condition to them in detail. And also, what they need to see us in primary care for, what they can use 111 or what the emergency department or urgent care would be used for. So I don't think that always happens fully, but that's what we need to try and sort of do next, is really delve down into this perceived immediacy. because what I haven't presented here is that just the perceived level of acuity, so how serious do they think it is, did not show the exact same relationship. So even when they thought it was less serious, they may still have found that, you know, there's a level of immediacy that they still need to be seen on the day or by emergency care.
Thank you. That's fantastic. And thank you for the presentation. It was really good. Thank you, Harry.
Shall I go next? It's Matthew Smith. I'm the Senior Responsible Officer for Urgent and Emergency Care for the ICB. Again, really good presentation. Very interested in that age correlation, which is not something I've seen before in quite that way. My question was, it's focused on ED and primary care, but does 111 or, for example, MIUs come into this anywhere? Because I suppose part of the national push and local push is to get people to ring first before they decide to go anywhere.
So on this occasion, I did not specifically go into details about that. In the literature review, I have touched base of some of those. But it has shown that in a lot of the units, in especially in the London area and wider, that some of these services haven't made much of a difference to the patients attending emergency department care. But what I have included, I guess, not in the specifically asking for UTCs or 111, is whether they feel that being located close to emergency departments or primary care services located within emergency departments would make a difference, but there was not that many patients who sort of agreed that that would make a difference, really. But again, I think these are things that we need to look at. I also didn't focus fully on telehealth because I think from what we've seen in the past that some of these things are in place and have been in place for a while. And in a lot of studies where they have looked at these in combination, again, when they ask the patient when they are in the emergency room, you know, did you call 111 or why did you go to a UTC? You know, the answer is always the same, because they couldn't get access, so they couldn't get in. It was easier to come. So I wanted to kind of find out from before that, what is it that they used to make this decision in the first place? But I think these are things that we need to look at in more detail about, and I guess that's what I said, that, you know, despite having UTC, 111, extended access, all these are primary care services that's kind of available, but yet it does not seem to be making much of a difference. And it may be that it's just that communication, educating patients on what is available and what is appropriate according to the level of acuity, but also immediacy for where you can access these services.
Yeah, thank you. Easiest option wins in some ways, I think. Yeah.
Yeah.
Hey, quick question, Isber. Hey, I'm Nils Olsen. I'm Isber's mentor. I have a PhD in psychology. I actually do behavioral economics. Decision making is kind of my area of research, but I do work quite a bit in the medical realm. And Isber and I have been working on this for quite a while. This is the first time I'm actually seeing the presentation. It's a great job. One question: those little thumbnail sketches I'm assuming those are correlation coefficients, the scatter plots, where you have perceived immediacy. Yeah. Is that significant? Is that one statistically significant? Because it looks like visually, it doesn't look like it would be statistically significant.
So the immediacy on level of immediacy for decision to attend emergency care was statistically significant. The one on primary care was marginally significant.
Okay, that's right. Yeah, I remember that right. Now, the other thing I was going to offer up, and you and your colleagues, your medical colleagues, could really shed some great insight on this, because you literally see this firsthand. But do you think it's also possible that when people go to an ED, emergency department, emergency room, the likelihood of getting some sort of therapy might be higher than when they go to a primary care provider? Now, in many cases, the primary care provider may very correctly not recommend something. In fact, that is a recommendation, right? And they're being more conservative in their treatment. Whereas could be a very high likelihood that at the very least, someone's going to get saline fluids through an IV, right? Just to make sure they're not dehydrated. So is it possible that patients are sort of implicitly realizing this, that like something is going to happen if they go to the ED versus maybe something is not going to happen if they go to primary care. And maybe it's warranted that nothing's happening, you know, in some cases, of course.
So from my opinion and sort of information I've got, I do think that plays a role, and that probably is where the perceived level of immediacy comes in, that they think they need to be seen urgently, and it may not be just to be assessed, but for tests or treatment and things like that that needs to be done, and they can't wait for the next available appointment. That is what sort of in a lot of occasions would drive their decision. And I think, again, that is maybe something to explore a bit more in sort of further research. I think we're up for the 20 minutes, so I may need to stop the recording. I'm happy to stay on after for a few more minutes for any further questions, but I would like to thank everyone for taking part and the contributions. It's really greatly appreciated.